This is a run-through of the Wellington ICU COVID intubation. This is a copy of our intubation checklist. Initially looking through the assessment column, things to consider are: is a difficult airway predicted and can we optimise our preparation? Should we consider some pre-induction sedation for agitated or less compliant patients? Could we remove any excess facial hair if time and safety allows? Is there a risk of physiological compromise? We anticipate that these patients will desaturate during the induction and intubation process. Does the patient have any known allergies? Are the ICU, SMO and ACNM aware that we are intubating a confirmed or potential COVID patient? Importantly, we should communicate with the patient and their family and discuss goals of care before proceeding. Whilst running through the intubation scenario, we'd like you to pay particular attention to the use of the ET tube clamp and turning of the oxygen on and off, which of course is different to our usual practice. Now we'd like to draw your attention to the equipment in preparation for intubation of the COVID patient. Starting with the airway tray, this will be pre-prepared outside of the patient's room and should be checked through thoroughly to ensure that nothing is missed prior to entering. In this box will be 2 ET tubes, a syringe, anchor fast for securing the tube, some lubricant gel, a bougie, an oropharyngeal airway, a nasogastric tube, and a videolaryngoscope with one blade. It's very important to check the battery for the videolaryngoscope prior to entering to make sure that you have enough battery life left to proceed with the intubation. This is also a good time to check through the sizing of the equipment that you might choose to take in with you, including the size of the ET tubes, the size of the oropharyngeal airway, and also worth considering the size of the eye gel that will be in the patient's room. Next will be the tray of equipment that will remain in the anteroom, outside of the patient's actual room. This will be some backup airway equipment which can be made available at short notice should you require it, but doesn't necessarily need to be taken into the room. This will include a spare videolaryngoscope blade and a direct laryngoscope. For the purposes of intubation of a COVID patient in Wellington ICU, we now have an allocated negative pressure base, which is the south base. We also have 2 negative pressure rooms. These are rooms 17 and 18, both of which have an anteroom. In the event of intubating the patient in either room 17 or 18, donning and running through the checklist should first occur in the anteroom prior to entering the patient's actual room. With regards to south base, donning and running through the checklist will occur outside the patient's room in the large negative pressure area. Whilst the team is assembled and running through the checklist prior to entering the patient's room, it is worthwhile talking over team roles. For our intubation scenario, we have an experienced intubator, a second doctor administering the drugs and managing physiology, an experienced nurse who will become the airway and ventilation assistant. The bedside nurse and airway assistant is likely to be inside the room already with the patient, whilst the runner can go through the checklist with the team outside. During the checklist procedure, it's important to run through your airway equipment and adjust any sizes. It's also important at this stage to run through a drug check.
Induction agent.
So we've got ketamine, we use 2 per kilo, so 160 milligrams.
Awesome. And muscle relaxant.
Rocuronium, 1.2 per kilo, so we're going to use 100 milligrams.
Awesome. For vasopressors.
We've got nortramenol and adrenaline.
And then for post-intubation sedation.
There's propofol.
Drawn up. Awesome.
At this point, you may choose to alter the drugs on the checklist. That is perfectly acceptable, but should be discussed with the team before entering so that everyone is aware of what will be happening once you enter the room.
Okay, Stan, how are you doing? The doctors are just getting dressed up to come in and put in that breathing tube we were talking about. Just help with your breathing a bit. Hi, Sarah.
My name's Sarah and this is Jenny. We're a couple of the doctors here. We're just going to get things ready and all prepared for this breathing tube. So we'll explain what we're doing as we do it. First of all, I'm just going to check that these arms are working.
You're just going to feel me squeezing on your arm again. It's going to go up a little bit more frequently now.
Jenny, just let me know when you're ready to do the
You alright, Stan? Do you have any questions about what's going on? You're ready to just tip on. Jenny, can I do anything?
I think I'm good to go. Oh. Okay, so we're ready to go.
Once in the room, we should do another check through the intubation checklist with regard to the patient in-room equipment. This includes an ambu bag with an attached PEEP valve, viral filter and end-tidal CO2. Suction, which includes both Yanker suction and inline suction, both of which should be connected before you proceed. An ET tube clamp, which should be at hand always. An eye gel, which will live in the patient's room, and preparation for a surgical airway, which will include a scalpel, bougie, and a size 6 ET tube. Next, we should ensure that the ventilator is set up and ready for our patient. This will include adjusting the patient particular settings and the ventilator settings. With regards to patient monitoring, we should ensure that a SATS probe is attached to the patient, the end-tidal CO2 cable is connected to the ambu bag, there's ECG monitoring attached, and the blood pressure, which is likely to be non-invasive at this stage, is cycling every 1 minute.
Okay, any questions or concerns?
Nope. So plan A will be a video laryngoscope and bougie. Plan B, eye gel. Plan C will go back to face mask, two-hand technique plus a Gadel. And plan D will be a surgical airway. Happy? Okay, you guys all good?
Yep.
Okay, Kathy, you can give me a hand.
At this stage, the intubator will turn off the oxygen running through the non-rebreathe prior to removing the mask, and the airway assistant can turn on the oxygen flow attached to the ambu bag to 15 litres per minute. The ambu bag will then be fitted to the patient's face with a two-handed technique, counselling the patient through this and reassuring them of what you're doing. We would advocate for starting with 15 litres of flow and however much PEEP is required to achieve the best possible oxygenation whilst minimising the leak from the mask. The patient should then be pre-oxygenated with a good two-handed seal over the face mask for approximately 3 to 5 minutes, aiming to achieve the best possible saturations prior to induction.
Okay, so saturations are 91, so...
Are you happy, Kathy? Yeah, happy. I'll check the cuff.
Okay, so we're just going to get you off to sleep now, Dan. Going to give 160 of ketamine. Followed by 100 of rocuronium. Start the timer.
Okay, and then when you're ready, Sarah, you put the head down.
Once the drugs have been administered, you can then use this time during induction to reposition your patient, to lower the head of the bed and position the patient appropriately for the intubator.
Okay, that's good. Thank you.
Okay, and that's 1 minute up.
Okay, so I'm ready to have a look. Kathy, you switch the oxygen off, please.
Oxygen's off.
Thank you. And I'll take the video scope. Fix the video scope. On. Okay, bougie, please. Okay, I've got bougie.
I've got the top of the bougie there.
Okay, I've got Richard. Okay, bougie out. And then cuff up.
Cuff translated there.
Okay, oxygen on.
Hopefully you've got end-tidal CO2.
Great. Okay, so if we can secure that.
Okay, still just sticking this down onto your face there. Yep, that's secure there.
Okay, and then we'll be ready to put on.
Once the ET tube is secured, prior to disconnecting the ambu bag, it's important that the airway assistant then clamps the tube. The oxygen can then be turned off at the ambu bag supply.
Clamps there.
Okay, oxygen then off.
The ambu bag disconnected from the ET tube before connecting to the ventilator circuit, removing the clamp and starting ventilation. At this point, it's important to remember to disconnect the CO2 monitor from the ambu bag cuvette and clip it directly onto the cuvette attached to the ventilator circuit.
Stand. Feeling good, tidal volumes.
And I have started the propofol.
Great, and I'll get ready to put this NG tube in.
It's looking good there. The sets have come back up.
Okay, cool.
Once ventilation has been confirmed, the intubator can then insert a nasogastric tube, the position of which can be confirmed with a chest X-ray once everyone is ready.